So this is Dr. Susan Dashu. She's one of the ECMO intensive care consultants at the Glenfield, and also the clinical lead for the Acots transport service. And I think you're going to talk about transport of the critically ill patient, I believe.
Yes, because I don't know how to talk about anything else anymore. Right, I've got bad feedback. Can anybody else hear that? Was that okay? Yeah, I think that's solved it. Now you're muted. Lovely. So good afternoon. Yes, as Matt has said, Susan Dasher, one of the ICU and ECMO consultants, and working at Glenfield, and yes, clinical lead for Acots in the East Midlands. Hopefully my slide projects okay in your rooms, but essentially this was a patient that I transported over 10 years ago now from Fiji around Christmas time. So yes, so those of you can see this slide, it was a patient that I transferred out of Fiji sort of more than 10 years ago. So hopefully, I've hopefully shown that I've got a bit of experience in transporting critically ill patients by now over some interesting distances. And also doing transport in some slightly interesting places. So this was in a canyon in Australia, in Sydney. And really to show that, actually you can achieve safe transfer regardless of where your patient is and where they need to go to and what the issues are. The rules apply the same regardless of where you're transporting them from and to. And it's about being prepared for unexpected occurrences. So I've asked me to talk to you today about a transfer, partly because I do transfer as part of my everyday job doing ECMO here at Glenfield Hospital. But also I've got sort of, as I said, quite good experience of doing this in some interesting places, and both for ECMO and previously. I have run the Leicester Transport course since starting as a consultant here in 2016. We haven't run it over the last sort of 12 or 18 months, mostly because we've all been a bit busy, in case anyone hadn't noticed. But hopefully we'll start to get some training back up and running again soon. And as I said, I'm the clinical lead for Acots, currently in the East Midlands. So lots of people have had lots and lots of questions about, it's a very apt email that's just come through. Lots of people have asked lots of questions about Acots and what it means for them and what it means, for the future of critical care transfers. So I thought it's quite important that I spend a little bit of time just talking to you about Acots currently. So Acots is the Adult Critical Care Coordination and Transfer Service. So the background to that service is that it was precedented from the paediatric world, who've been doing this as an established service for much longer than adults. And it really shows that transfers are better achieved by experienced teams who do this as part of a specialised part of their work. Obviously, with the COVID pandemic that started around March, April 2020, the West Midlands launched their Acots service and was very much an ad hoc service and provided cover that they could on a particular day. We've sort of developed that in the East Midlands using coordination service only and with ambulances available from July of last year. And then we went live with clinical teams as of January this year, which hopefully most units have seen the benefits of. There is now a national transfer service specification that's been published. So if you type transfer service specification into Google, it'll come up with this document, and it's got some important and useful information around building a transfer service. So we've been running a temporary service since January of this year, and will continue up until April of next year as a temporary service. And so there are coordinators, which are all ICU consultants on a 24-hour basis. Referrals are received via refer a patient now for routine or capacity transfers. So hopefully when you need to do transfers for capacity reasons, you'll see those referrals coming through from your end. We have a call handling service, which is a single point of contact, which should be available in all your units, but it's there on the screen. And that's really important because we ask that all time critical transfers should be phoned through in the first instance, because we appreciate that filling in refer a patient takes a little bit of time. And actually, we'd like to know about these patients as early in their pathway as possible. So patients who present to ED with a signs of a significant head bleed, for example, or they're a MI patient who's going to need to come to the cath lab. If we know about that patient as early in their pathway as possible, we can be dispatching an ambulance plus or minus a team to you whilst that patient is being stabilised, intubated, scanned, accepted at neurosurgery, for example. So that's why that early phone call is really important. The coordinator will obviously discuss the referral with the most appropriate clinician. It doesn't have to be a consultant, it's just a clinician who knows the patient well. If it's a capacity transfer, that coordinator will aim to locate an appropriate ICU bed for the patient to then be transferred onto. And then there's clinical team are activated via our secure messaging apps called Silo. Clinical teams are provided at the Newark and Glenfield base on an 8 to 8 basis, 7 days a week. Then that's usually a consultant in either intensive care or anaesthesia, and then a transfer practitioner who may be an ICU nurse by background, an ADP or an ACCP, and hence the umbrella transfer practitioner. The teams are not every day at each base, and that's just because all of the service currently is on ad hoc and additional basis, and that's part of it being the temporary service before we get into our fully commissioned service. So John's ambulance service have been commissioned now to provide our ambulance service for this service. So it's giving us 2 vehicles in the East Midlands, 8 till 8, and an overnight vehicle based from Newark. But across the Midlands, there are 4 teams on any day, and we use the teams from across both sides fairly interchangeably to give cross cover and to give some resilience to the service as well. So the only other useful question that you might be asked is, how do we get into your hospital and into your building where the patient is? So please provide as much information of that as you can. Obviously, the service as it becomes commissioned will be looking at fulfilling 95% of the time critical escalation of care transfers. We appreciate there may be occasions where either all our clinical teams are occupied doing other transfers, or actually the amount of time it's going to take for a vehicle with a team to get to you will be too long, and actually we need to try and see whether EMAS can facilitate that. Always refer via the referral number though, and the Acots coordinator will arrange any vehicles with EMAS that are required, so you don't need to do that. The Acots system will do all of those jobs for you. And obviously, because of the planned nature, all repatriation and capacity transfers should be completed by the Acots service. So moving on to where we're going to get. So hopefully it will be it's a work in progress, as all these things are, but hopefully this organogram kind of shows some of the key relationships that this service is going to have. So it's across the whole of the Midlands. We will, as a senior leadership team, function as one service, and obviously, as I've already said, there's lots of cross cover across the 2 services, feeding into the East and West Midlands host trust organisations. Obviously have really important links with the West and East Midlands critical care networks, and we will have a service manager to support us in all of that as well. So there's lots of key roles that are going to come into starting to support this service. I'm quite glad, because I'm getting a bit grey. Hopefully you will have seen or had sight of some of the useful documents from Acots now, really principles about mutual aid, when to refer for mutual aid. These are really at sort of consultant and service levels, but they are interesting for you to have a look at. And then it's a clear document about how to refer to Acots. I'm sure lots of you are kind of au fait with the referral patient system at this point, so hopefully that is fairly intuitive and it's fairly, step by step in that regard. The important one is sort of information for patients and their relatives about doing transfers, and that's really for all transfers, but also for capacity transfers, because obviously that's quite an emotive subject, saying, we're moving your relative to another hospital because we don't have enough room for them. Understandably, some families find that quite challenging, and it's about how we communicate that carefully with them, but that document does help to lay out some of those. Not surprisingly, I've had lots and lots of questions about what it means for me, as in from other people. What does it mean? Because lots of people have expressed some concern about not having opportunities to do critical care transfers as registrars. Concern that, you know, from a nursing point of view, that overnight, what do I do at 2 a.m. when I haven't done one for ages? Now I'm de-skilled, and I really want to be able to keep my skills. So clearly Acots was set up in a little bit of a hurry to fulfil the needs of wave 2 to 3 COVID pandemics. But clearly moving forward in a fully commissioned service from April of next year, we will have lots of opportunities. So we've had opportunities for consultants to bring some of that work that they have been doing within their job plans and make it a little bit more sustainable. From a registrar point of view, we're hoping to be able to start bringing people on board to do some of the ad hoc work, but also for those people who need it for as part of their sign-off, etc., to do that as an observer shift as well, so you can have proper supervised events with a consultant to make sure you can get signed off for critical care transfers. I laughed because the email that dropped into my inbox just as we were talking is actually a job advert for a fellow at Glenfield, for both ICU at Glenfield, but giving some time to the transport service. So half time on the units, half time to the transfer service, which I think will be a really exciting fellow opportunity. We will obviously also be having nursing and allied health professional staff as transfer practitioners rotating into the service on a rotational basis, but also making sure that we provide support for observers so that when it is 2 o'clock in the morning, they feel like they still have the skills to do that. Should we not be able to provide a team at night time? And that's, in the first instance, we are probably not going to be able to provide a nighttime team in the first year, just for funding constraints. We hopefully will also have lots of education and training opportunities, both for provision and for attendance, and we hope to start running some transfer training courses again into the next financial year. I'm going to talk a little bit about transfers next, but I'm just going to pause there to see if anyone has any specific questions about Acots that they would like me to answer. Stunned silence.
I got one.
Yeah.
The form that you fill in for Acots, does that only stay with Acots, or does that go to referring? Because often it feels more detailed than maybe the discharge letter that gets produced.
Yeah.
Does that get sent to the transferring centre, or does that?
Yeah, so it should. It should. All these famous last words, but our coordinators send that on both to our clinical teams who are transferring the patients, and also send it on to the accepting consultants at the unit, because yes, it actually gives you a very thorough discharge summary.
Fine, so we can use that as our, on the ones where they're more acute ones that we haven't prepared, we can just do one form.
Yeah.
Awesome.
Yeah. So yes, it does provide quite a good discharge summary. Lovely. So I'll talk a little bit about transfer. If anyone wants to talk to me about Acots or opportunities, or how to make sure that you get your transport modules signed off, then just drop me an email. So just talking a little bit about transfer per se. Obviously, there's lots of things that influence the level of resuscitation we might do prior to transfer, and that's really going to depend about what the problem is with the patient, what their immediate needs are, what care they're going to. So what are they going to be getting at the referring unit? From a capacity transfer point of view, obviously we need to make sure the patient's buffed up and shiny and stable for transfer. But actually, a patient who's needing a craniotomy, for example, actually they need to get there urgently. So getting them there in a quick fashion is important. It's a balance of those things for every transfer we do. Might also be limited by what can be done en route. So this is particularly for sort of some of the aeromedical transfers. Actually, in some of the smaller helicopters, it's very, very difficult to access the left side of the patient. So if you've got anyone with a left side of the chest concern, you might want to be making sure that you have drained that really small pneumothorax before you get airborne. Obviously, lots of the air ambulances now have much bigger aircraft, so it's less of a consideration, but it is something to think about. Where are you going to be and how can I access my patient? Obviously, weather and daylight will affect transfer because it, particularly for air, but obviously, you know, we had some really awful days last winter in the snow. You know, actually we have to think about, is it right to be doing capacity transfers and putting those patients and our teams at risk to do capacity transfers when the weather and the road conditions are so terrible. Might also be dependent on the expertise of the team and what you're happy to transfer. And obviously, you know, Matt and I get in the back of the ambulance with some really sick lung patients, which we would not expect most of you to be keen on doing, because they are quite a challenging subset of patients. And it's also about safety, and hopefully in the civilian setting we don't have to worry too much about our own safety and transfer, other than the safety of the vehicle or aircraft. But moving on to sort of your pre-transfer things that you need to consider, and that's really to make sure you've done a thorough A, B, C, D, E assessment, which sounds very contrite, because, you know, surely you all know that. But just some things, you know, that are important, and should do this in a stepwise fashion and do this at each move of the patient. So when you move them from, you know, do your full assessment, move them from the bed to the trolley, do that full quick assessment again, and then before you know, get into the ambulance, do that final check, and at each point of the journey to do these checks. You know, think about what is their airway like, and actually most of our patients will be level 3 transfers. If they're sort of a level 1 transfer, they're a ward step down, for example, which sometimes the Acots service supports, we need to be really happy that that is their trajectory and that everything is improving. What would we do if the patient then deteriorates? And in general, the transfer of patients on CPAP or NIV is not appropriate. You know, there are some times where that is their ceiling of care, and getting them to the right next place might be important, but I think it's, you know, that's a really complex decision, because actually they can have quite significant challenges on their transfer. You know, very simple things: make sure that you've recorded the depth and the intubation grade, and make sure end-tidal CO2 is in situ. Think about tracheal cuff pressures, again mostly relevant to air travel, because obviously the cuff can inflate and deflate depending on the level of altitude that you're at. Moving on to breathing, you know, we need to make sure this patient's safe to transfer from a ventilation point of view, but always think about how much oxygen you need. And I can't ever personally remember this oxygen requirement, so it's on, very helpfully, it's on the back of the transfer forms. It's on the back of the big red forms, which I'll show you at the end. So just do give yourself a moment to make sure that you've got enough oxygen for your transfer. Pretty unlikely you'll run out, because the ambulances have 2 large sort of ZX cylinders. We've got 2 large E cylinders on the trolley. The ambulance often has some CD cylinders in the vehicle as well, packed away. So it would be unusual to run out of oxygen. However, if you've not asked your driver if they've run out of oxygen because they've been on transfers back to back all day, it is always something to just make sure if you've got a particularly dependent patient. So don't feel that you need to remember this, but do make sure you know where to look it up. Obviously, make sure that you've done a thorough assessment of the patient. Make sure that you've got an idea of what their end-tidal CO2 is as calibrated against their PA CO2, because again, that's the thing that you're going to be comparing against when you're in transit. Think about HMEs. You know, from an airway dryness point of view, it's really important that we're in transit, that we still make sure that we're humidifying the airways. So do always add that into your breathing circuits. If they have significant pneumothoraces, it's always worthwhile draining them, particularly prior to air transport. And as I've said, there may be some access issues in some of the ambulances for some patients. So think about it. I say significant because actually if they're small rim of pneumothorax, I wouldn't necessarily rush into draining that prior to air transport. So circulation, you know, hopefully not teaching you to suck eggs here, but very simple things. And it's all the things that have easily gone wrong. Make sure that you've got good access. make sure that you've got access that is checked and secured, and always make sure you've identified a port for drugs and a port for fluid boluses on en route. So if you're nicely wrapping them up and they're all snug in, that's brilliant, but make sure you have access somewhere to bolus drugs and fluids. Make sure you've done a full assessment of the patient. Obviously, using non-invasive versus invasive BP is a debate depending on which phase of the journey the patient's in. So invasive blood pressure would be, for every ICU patient, is generally what we're used to. But obviously, if you've got a sick patient who's neurosurgical head, for example, or one of the post-cardiac arrest patients who needs to get to their intervention, I would say if it's very straightforward, carry on. But actually, if it's delaying you and it's taking time, actually, it's far better to go with non-invasive and get them to the treatment that they need. Vasoactive requirements might change significantly during transport. You might need less because they're getting more sympathetic drive because they're being jostled around in the back of an ambulance. But they may need more because they're being destabilised by that as well. So make sure that you take plenty of drugs with you. Management of the acting bleeding patient can obviously be quite challenging. And it's that, again, that's a balance between, does the surgeon need to come to me versus can I put them in the back of an ambulance safely? So, we make sure that we do sort of a balanced resuscitation of that patient, try and correct temperature, acidosis, and significant things that, we can do something about. We can talk about splinting, long bones, make sure we've got pelvic binder for pelvic fractures, all those sorts of things. But actually in the ICU world, it's less likely. It's more likely to be an acute surgical bleed or a obstetric patient who's got a postpartum hemorrhage who needs to go to another centre. But hopefully, surgeons to them. Make sure you do a good D assessment. Mostly because, particularly the neuro patients, we need to know what their GCS was prior to intubation, prior to transfer, and particularly things like lateralizing signs. Always think about eye protection, so taping the eyes for transfer so that we don't cause corneal damage whilst we're moving the sheet, we're leaning across and to plug the oxygen in. All those things can cause very, minor things in the grand scheme of why you're transferring them, but actually can have quite a big impact on patients as they start to recover. But always make sure you can check the pupils. And importantly, remember spinal precautions for those that are important. Don't ever forget glucose, which isn't on my slide purposely because, it's the thing that people do forget. So think about it and think about the ability to monitor your BM en route because you're stopping the NG feed for transfer. So if you're turning the NG feed off, make sure you turn the ACT rapid off and actually just keep an eye on the BMs, particularly if it's a longer transfer. Exposure and environment is important. Clearly on days like today where winter's starting to come, it feels a bit chilly out there. And actually, as we head into the winter, actually keeping the patients warm in transit is really important. Having obviously worked out in Australia, where they were always told about having the patient's sunglasses, so actually have sunglasses in your kit so that you can give them eye protection, because actually it can be very, very bright if they're looking directly up whilst they're being loaded into a vehicle. And obviously things like hearing protection is important on helicopter transfers. Think about penetrating injuries or burns, because they may be quite important. I transferred a patient from Darwin to Adelaide, which is a long trip down the centre of Australia, with a sea level cabin, which took a long time because obviously the sea level cabin, because he'd actually got an intraocular penetrating injury, and that's the nearest neurosurgery and ophthalmic centre that they could look after him. So it was a really long transfer, but actually making sure that you do that carefully is really important with close control of all the things that's going to change your intraocular pressure. Make sure that everything that's attached to the patient has been secured, documented and emptied prior to transfer. No one wants the BMS making a mess in the back of an ambulance on the way because it's got squashed between pieces of equipment. So try and empty everything that you possibly can. Yes, there we go. Yes, this was a patient that I put in the back of an ambulance. just in case you can't see the screen so well, it's a tachycardic, hypotensive, hypercapnic, slightly hypoxic patient with airway pressures of 40/18 at a rate of 40. So no, I didn't just put them in the back of an ambulance. This is a patient we were going to assess and retrieve for ECMO, and they've actually deteriorated quite significantly between referral and acceptance of the patient. So we hadn't taken an ECMO circuit to this patient. We were going to go conventionally. So actually, it's the things that you can do to optimise these patients to make sure that they're safe to transfer. It wasn't a quick turn up, package the patient, turn back around and come home type patient. It was a patient that did need some stay and play and starting to get them more stable before we could think about transferring them. And actually, I did a lot of turning knobs to the left, getting their airway pressure down, getting their peak down, turning their rates down, adding some vaso, but actually just turning everything to the left made their blood pressure a bit better, which meant that they were able to come back for consideration of ECMO. Hopefully, you all know well your AA-GBI minimum standards of monitoring. It still applies in the back of an ambulance. So, we need to make sure that we are doing as our very much minimum all of these things. So hopefully, during all of that, we've talked about doing a good assessment of our patient. That means that actually we can stabilise them sufficiently to put them into any mode of transfer, whether we're just doing an inter-hospital down to the CT scanner type transfer or any of the other modes of transfer there. It doesn't matter how you're transferring these patients, the same rules of preparation apply. Plan ahead for your journey. So, plan ahead, if you think there's going to need to be ongoing fluid resuscitation, or if you're going to need blood on the journey, always make sure you think about what you need before you depart. Make sure you've got plenty of drugs, and allow for things to change and things to be delayed. When we have time, somebody can ask me about some interesting trips, back from Fiji, but also bringing an ECMO patient back from Scotland that was somewhat more circuitous than I would have hoped, but making sure that you had enough drugs to make sure you could make that trip. Think about things like defib pads. Do you know where they are in the ambulance? How do you access them? Actually, have the patients, a post-arrest patient, actually, do you need to have them on before you're starting the transfer so that they're just there ready should there be the need in transfer? Packaging is important for the patient to make sure that they are warm, so you're minimising environmental exposure, but making sure that you know exactly where all your lines are, that they're secure, that you aren't going to pull out the NG tube, and that all the cables and everything are in situ and aren't going to be wobbled or anything in transit, so that actually it is nice and safe and secure for transfer. And you can sort of mummy wrap them, which is hence the picture, really tightly. This slide is quite important. It's safety. So these statements are taken directly from the FICM standards for transfer, and I think it's really important. So everything in the ambulance should be secured. So everything should be on the transfer trolley, should be rated to be in transit. All the pumps, ventilator, etc. should all be secure, because obviously they could be a quite significant missile in the event of an accident. All transfer bags should be stowed, so either in the back of the ambulance they should be strapped with seat belts or put into the ambulance cupboards, and the ambulance drivers will help you with that if you ask them. High-speed journeys should be avoided except where strictly necessary. So in the old days we used to go on blue lights to pretty much anything. You get a level 3 patient back in an ambulance, or put lights on. But actually we've stepped back from that quite significantly, and for all our capacity transfers, blue lights are not required unless there is significant, motorway traffic or significant delays getting into a city. Actually, and that's really just to make safe progress through traffic, so the journey isn't significantly delayed. But otherwise, they should all not require blue lights. Should be normal road speeds. And it really is about just making safe passage through traffic. You want to really deliver a safe and smooth transfer. And obviously thinking about patients who've got neurosurgical heads, etc. Actually, acceleration and deceleration can be quite harmful with the fluid and pressure shift. So we just need to make sure that it's nice and safe. For you, make sure that you're seated with your seatbelt on. You know, the rules of the road apply to you as well in the back of the ambulance. So it's important that you're safe. And actually, if there's anything the patient needs doing in transit, it should be a stopping at the side of the road so that you can safely take your seatbelt off. Obviously, securing the patient safely on the transfer trolley as well. And it's always a little warning, I say, accidents do happen. There's always reports of ambulances having collided with something. Make sure that you have significant financial arrangements in place in the event of a serious accident so that you could pay the bills. And that is that both the AAGBI and the ICS provide that as part of their memberships. So not advertising either in preference.
As part of the membership.
Yeah. So moving on to documentation and handover, hopefully you've all seen the Midlands-wide critical care network transfer documentation. This is what we're using currently. So it's a bit like a big anaesthetic chart with lots of tick boxes on, and there's lots of information on the back, which will help you A, prepare, and B, ensure that you've done an adequate handover when you get to the other end. Obviously, it's important that you complete this and then leave that documentation with the patient. If there are critical incidents, it should be reported via the Trust's DATEX system appropriately so that we can learn from events. And a formal handover should occur to the accepting team. So make sure that when you take a patient somewhere that actually there is a medic receiving that patient as well. So you can have a formal professional handover. Probably, Matt, what I'm going to do is there's lots of very specifics there, but I think in the interest of time, I'm happy to take questions at the end, but overall it's important that you know your patient before you transfer them, spend some time doing a full assessment of that patient and a clinical examination before you get in the back of an ambulance. Plan for possible deterioration, so what are you going to do? Does the patient have a DNAR? Because actually that is appropriate sometimes. What would you do? Would you go back to the referring hospital? Would you continue to the planned hospital? What would you do in the event of a cardiac arrest en route? There is a bit of stay and play versus scoop and run. So obviously we've talked about the neurosurgical emergencies. It's a bit more, let's get on with it. The patient that showed you there for the ECMO retrieval, actually there was quite a lot of stay and play to be able to stabilise that patient, to be able to safely transfer them. Think about using your monitoring. We do have some portable ultrasound machines that we use for the ECMO retrievals. So, and again, hopefully that's something that we will achieve for the Acots service. So it's that balance between not spending too much time with the patient and getting them moving, but also making sure that you've done a really thorough assessment and if there's anything en route. Think about the risks and benefits of driving with blue lights. Actually, is it necessary for this patient journey? We need to make sure that we're safe. And actually, from an Acots point of view, and the drivers are now really good at it, actually it's the coordinator's decision about whether or not blue lights are appropriate for that transfer, and it's the driver asks permission to the coordinator about whether or not that's suitable for that journey. And like anything in medicine, good communication is really the key to success at each step of a transfer. As I'm sure you could imagine, I can speak endlessly about transport, but I think probably in 40 minutes chatting to you about the Acots updates is important, but also a general overview of transfer. Anyone got any questions? Stunned silence, marvellous.
Thanks, Susan. That was a really good overview. I think it's handy as well to speak about Acots so that people think about it, because I think it's obviously quite a new service, and
but really, really useful, particularly in the pandemic, moving people around. I think a lot of centres have found it invaluable for freeing up capacity and whatnot. Any questions from anyone? Anyone at the Royal?
In regards to the training of transfer patients, why we are not arranging some short simulations for that while we're waiting for the official training for transfer patients?
I'm not sure I caught all of that, but I think it was asking about providing some short simulation training whilst we're waiting for courses. Yes, it's difficult. You know, in the grand scheme of things, actually, obviously, pandemic has been quite busy for everybody, and also being able to set up and run this service in addition to busy clinical work. The capacity for me as an individual has been quite limited to do any more of that. The network are running a couple of transfer days, and there's some trusts who are running a day here and there, so there is some opportunities within the region. But as I said, Acots will be looking into the next year to start running a sort of more formalised programme of training with all our new, very swanky new kit. So if I go back to here, hopefully you can see there our very swanky new transfer trolleys are coming online with a Hamilton ventilator, Tempest monitors, defibs, with all the Braun pumps. So actually it'll be quite a nice bit of kit, but actually with monitoring and ventilation that lots of people won't be familiar with yet. So it's about also making sure we're delivering training that's relevant to everybody and what the equipment that you'll be using.
Is that a national venture, Susan?
So yeah, so there's two strands to this. So there are, so from the Acots service point of view, in the East Midlands, we're going to have 6 trolleys. So we're going to have a lot of provision and redundancy for our 2 bases. But actually, each unit in the East Midlands Critical Care Network are going to have a trolley that's almost identical to this. So actually, all units are having an updated version as well. And actually, we've standardised the kit across them all. Sorry, there's a question in the room here.
What's the weight limit on the trolley?
So the weight limit on the trolleys is, so currently they're 180 kilos. But generally the challenge is actually, can they fit? So are the patients too wide to fit on the trolley? Because actually if they're my height and 180 kilos, you've got a bit of a problem. For those of you who don't know me, I'm 5 foot tall. But the new trolleys, I think the weight limit is the same, but obviously we'll know when they're actually all in place. But actually they've got ratcheting sides, so that actually you can not have to necessarily put the sides completely upright, so you can ratchet them, so you can, it's a little bit more give. And actually in the shiny new ambulances that we're getting, there's also an option to centre mount the ambulance trolley. So actually in terms of getting them in with them ratcheted down, it's actually also possible. Because let's face it, we're all going to be looking after bigger, fatter people.
Cool. Any other questions?
No.
You've got away with it.
I know, that's the easiest audience about Acots I've ever had.
Brilliant. So thanks very much for that, Susan.
For those of you who, I'm just trying to, like, it's kind of gone onto this, oh, do you know what, it's fine. But those of you who don't know me, I'm Anish, I'm one of the anaesthetic and ICU regs. I've just come back from my year of medicine a few months back to where I did 6 months of infectious diseases. So malaria is one of the things that I kind of find most interesting. And the reason I kind of thought I'd do a presentation on it was because I saw about 5 cases of malaria on the unit during what was meant to be sort of the peak pandemic. So people weren't really supposed to be traveling. So it kind of suggests that it's a lot more common than you think. And actually, when people are starting to travel again, the majority of us will probably see a case at some point. So it's based around a case. So what I'm going to do is have a look at the case. and then do a brief introduction into malaria, including epidemiology, pathophysiology, diagnosis and treatment. But I think one thing that's more interesting for us is to look at severe malaria and the sort of malaria that will be coming to the intensive care unit. So the definition of severe malaria, pathophysiology and treatment considerations. So if we look at the case, it was a 30-year-old lady of Nigerian origin who'd recently travelled from Nigeria. Now, she'd been taking a Malarone. Sorry, my brain's not working. And she was admitted with headache, fever and malaise. So in terms of her bloods on admission, hemoglobin was 100, white cells 3.5, platelets were 50. And she had a blood film done, which showed a parasite load of 7%, but it was actually later found to be 12.8%. So she was commenced on IV artesunate as per the trust guidelines on malaria, and then she was transferred to ACB. And it was while she was on ACB that she tanked the blood pressure, and that's when she was referred to ICU. So prior to discussion with infectious diseases on ACB, she was given quite a lot of fluid, and I'll tell you why that's important in a little while. She went up to ICU, she had a brief run on phenylephrine, and she continued IV artesunate and ceftriaxone. The parasite load dropped, and so ID advised changing to Riomet, which we kind of ignored because she still was quite unwell, but eventually we stepped her down. Now, while she was on ICU, she had a bit of a wobble in her LFTs, but we thought that was due to ceftriaxone. And because of her low platelets, we did a ultrasound of her abdomen, which showed quite significant splenomegaly. And after 8 days, she was discharged home. So that's just kind of like a brief look at a real case that came into hospital sort of last winter. So I've kind of just done a bit of a brief introduction into malaria itself. So malaria is a febrile illness. It's caused by the Plasmodium parasite, and it's spread through the bite of the female Anopheles mosquito. Now, there are 5 main species of Plasmodium that infect humans and cause diseases: Falciparum, Vivax, Malariae, Ovale, and Knowlesi. By far, the 2 that cause the biggest issue are Falciparum and Vivax. So Falciparum is more prevalent in sub-Saharan Africa, and Vivax is kind of in Africa, but also more prevalent around South America. So for those of you who don't know what an Anopheles is, I mean, it's just a mosquito. But in terms of the disease itself, affects 50% of the world's population, with about 228 million cases worldwide in 2018. And like I said, the majority of cases are in sub-Saharan Africa, and that's where it accounts for the majority of deaths. And there's a few reasons for that, mainly because Falciparum, which is probably the more severe form of the disease, is more prevalent in sub-Saharan Africa. But it also may be due to the conditions itself there that favour the life cycle of the mosquito. But that being said, Southeast Asia, the Eastern Mediterranean, Western Pacific, and Americas are still at risk of malaria. So this slide is a bit busy, but it's really, I think it's really important when you consider malaria as a disease to understand not only the life cycle of the mosquito and the disease within the mosquito, but also the life cycle of the disease within the blood. And the reason it's important is because it shows you exactly at what stage they are in the disease when you look at the cells under a blood film. The 2 main things that you need to know about are the liver schizonts, which are here, which is just when the cell's about to burst and release a load more parasite into the bloodstream, and the schizonts in the erythrocyte. That's what you're most likely to see. And your parasite load is determined by the number of affected erythrocytes you see on the blood film. So in terms of the pathophysiology, the reason why you get an anemia and a thrombocytopenia is normally the infected red cells would pass into the spleen and be sequestered. But the parasite itself causes a release of vascular endothelial factors, and that causes adherence of the cells within the spleen. So that obviously leads to anemia because you're sequestering red cells, but also leads to hemolysis, and massive spleen equals thrombocytopenia as well. So that's why you kind of get that typical picture on your full blood count. Interestingly, it also leads to accumulation of red cells within the microvascular endothelium. And that doesn't really have the effect that you'd think. It doesn't cause sort of obstruction of the microvascular endothelium. But what it does is it causes quite significant capillary leak and endothelial leak. And that's when you start to get into the realms of severe malaria. So if we look at the signs and symptoms, now the incubation period is between 12 and 35 days, which is why you'll get a lot of travellers coming back and then subsequently developing symptoms. And it's fever, headache, muscle ache, nausea and vomiting are your kind of typical symptoms. In terms of your signs, it would generally be fever, anemia, abdominal pain with splenomegaly, jaundice, and a lot of sort of fairly non-specific signs as well. So like kind of bruising and things like that. Now, in terms of diagnosis, it's largely done clinically. So traveller coming from either Africa or abroad with a fever and malaise is malaria until proven otherwise. I guess the kind of the issue that we had with our case was it was during the second wave of COVID, so it kind of all got mixed up into the whole this is COVID unless proven otherwise type thing, and it meant that the blood film wasn't done until she hit the medical unit. So there was an opportunity there to treat slightly earlier. Now, once you've got your microscopic diagnosis, so that's looking down the microscope and seeing the number of erythrocytes affected or infected with the parasite, it also involves quantification of the parasite load, and that's what I said in terms of your parasitemia is determined by the number of red cells that are affected on the blood film. And then there's other things like rapid testing and serological testing, molecular testing and mass spectrometry. I think ultimately when you can just look down a microscope and see bugs inside red cells, it's probably a lot easier than going down the route of mass spectrometry, but those are available as well. And this isn't really that easy to see on the screen we've got here, but what I was trying to allude to earlier was when they look at the blood film, the reason why it's important to know at what stage the parasite is within its life cycle within the body determines what you'll see on the blood film. And you can determine, one, what type of Plasmodium parasite it is, and two, at what stage it is in its reproduction. So along there's Falciparum somewhere, the top one. So that's the one you're most likely to see, and one that's associated with the most severe disease. Now, in terms of management, obviously prevention's better than cure. So nets, insecticide, anti-malarial, so atovaquone and Pregnenolone, so Malarone and Doxy. And to be honest, uncomplicated malaria is actually pretty easy to treat. You just give them some artemether and lumefantrine, or if they've got a problem with that, then quinine. And it's all actually, there's some really good trust guidelines for this, which have been written by the ID team. That tells you exactly what time and for how long you need to give the medication. So you don't actually need to look a lot of stuff up. Now, in hospital, all febrile travellers should be isolated, and you should send an EDTA tube with a blood film. Now, bloods also should include things like bloodborne virus screens, USNEs, LFTs, CRPs, and G6PD, mainly because that's associated with worse outcomes in malaria. Chest x-rays, urine dip, and MCNS, just standard stuff, because malaria doesn't just occasionally present with malaria, presents with a vast other number of other diseases as well. So you can get malaria and dengue and kind of combinations of diseases. So it's important that you send all the other standard investigations as well. Oops, sorry, just dropped the mouse. So kind of what we're more interested in is severe malaria. That's what we're more likely to see on ICU. And the reason I think it's particularly interesting is because a lot of the stuff that should seem quite intuitive in managing a sick patient aren't necessarily indicated in treating severe malaria. So the WHO definition is the presence of malaria with one or more of low consciousness, convulsions, respiratory distress, circulatory collapse, jaundice or coagulopathy. Now, in terms of your lab findings to define severe malaria, it's a hyperparasitemia, and that's kind of the definition is a little bit vague across different guidelines. So the WHO recommend it as greater than 2% on your blood film, but I've seen it up to 5% before it gets classed as severe malaria as well. So it's just important to know that anything above 2 is probably worth paying a little bit more attention to. And then other signs of things like renal failure and anemia, pulmonary edema. Again, as I mentioned, the endothelial damage can cause fluid leak into the pulmonary interstitium and can lead to edema. So in terms of the risk factors for severe malaria, it's falciparum malaria, pregnancy, children, immunosuppressed patients, and patients with a parasite load of over 2%. So as we remember from the case, her parasite load was nearly 13%. So she had a really significant parasitemia. Now, in terms of the pathophysiology, one of the things that is associated with the worst outcomes in severe malaria is cerebral malaria. So it's an encephalopathy, and it presents with delirium, impaired consciousness, and seizures. And it has a relatively large mortality rate associated with it. And it's all to do with the sequestration of erythrocytes into the cerebral microcirculation, and that damages the blood-brain barrier and leads to cerebral edema with quite significantly raised ICPs. Now, the reason why it's interesting is because although someone with a huge ICP, you'd kind of consider something like osmotherapy, actually that's associated with significantly worse outcomes in both worsening your likelihood of death and also worsening your likelihood of prolonged coma. And the reason is thought to be due to it affects fluid sort of transport across an already damaged blood-brain barrier. So it's something that should definitely be avoided. And then standard stuff for coma and convulsions is balanced neuroanesthetics and standard neurocritical care measures. In terms of cardiovascular compromise, it can be as a result of a number of causes. Anemia can cause ischemic cardiomyopathy. You can also get your microvascular complications, and also having a massive spleen can cause quite significant aortocaval compression. Now, the majority of patients will present with a dry cough, and severe malaria, as we kind of mentioned earlier, can result in an acute lung injury, and it's sort of a non-cardiogenic form of pulmonary edema. Renal, so sepsis, hyperparasitemia, hemolysis and rhabdomyolysis all contribute to renal failure, and as we mentioned, there's lots of hematological sequelae from severe malaria, including anemia, thrombocytopenia and coagulopathy. Hypoglycemia is really common as well due to the utilization of glucose by the Plasmodium parasite. So In terms of management of severe malaria, there are quite a few very specific things, particularly in the case of malaria, to keep in consideration. Early steps are always kind of the same. So you give them anti-malarials, you give them sort of careful fluid. But the reason why early vasopressor support is recommended is, again, as we mentioned earlier, if you start flooding these patients with fluid, even when they're hypotensive, all you're doing is increasing their risk of quite significant pulmonary edema. And that is a fairly common cause of death in malaria as well. So giving ceftriaxone to cover malaria complicated by sepsis, this kind of seemed a little bit wishy-washy when I was trying to ask the ID guys why they did it, but it's something we do just because, I think. Hematological support, including clotting and transfusion if necessary, and managing renal failure and cardiovascular collapse, ARDS and acidosis are all kind of things that we manage routinely on ICU. In terms of pharmacological management, first line in severe malaria is IV artesunate. So artesunate is an artemisinin analog, or a derivative of artemisinin. No one actually knows how it works, but it's thought to interfere with parasite protein synthesis, and it very, very rapidly brings down parasite loads. Again, it's really, really nicely laid out in the trust guidelines as to exactly when the artesunate needs to be given. If there's a contraindication to artesunate, you can give IV quinine, or it's not available, you can give IV quinine. And the reason that's important is if you're in like a random DGH in the middle of nowhere, where they don't really see many cases, occasionally they'll only have quinine, but it's really important to make sure that they get something rather than waiting until they get transferred to a tertiary centre with ID units and stuff like that. Just because if your parasitemia remains significant, then that increases your likelihood of a worse outcome, particularly if it progresses to cerebral malaria. And then once the blood film clears, you can convert them to oral therapy, and that's Riomet. But also you can give quinine and doxy or clindamycin, and also if you're really struggling, you can give Malaria as well. Once the blood film's cleared. So that's just kind of a fairly brief intro into malaria. I thought it was quite an interesting disease, and I think it's something that is on the FICM curriculum, so it's worth knowing about. But has anyone got any questions?
Hiya. So the Riomet.
Yeah.
It after the blood film is clear. So
yeah.
8 hours is after the last blood film, which is showing clear from parasitemia, and then we will start Riomet, or 8 hours from the first diagnosis.
So I don't get what you're trying to say. So in terms of when you're starting Riomet, do you do it? So if there wasn't a significant parasitemia to begin with, so if your parasite load was less than 2%, you just start Riomet straight away. If there's a severe case, you give artesunate. Now artesunate will clear your blood film straight away, more or less, but it's really important to stick to the guidelines in terms of when you give the artesunate before you switch to Riomet. So you finish the course of artesunate before you switch to Riomet.
And in regards to the quinine, is it just a second line, or have to start it anyway?
No, so quinine is a second line in the majority of the guidelines that are read, and particularly in the case of severe malaria. It was more because it's a little bit hit and miss when which units will have artemisinin analogues or not. So in those circumstances, the vast majority of hospitals will carry quinine, but they may not carry artesunate. So it's really important to start something. So in those cases, that's when quinine is indicated.
Thanks for that presentation, Anish. That was really interesting. I think the fluid thing's quite interesting for malaria. So
the difficulty is you'll see these patients after they've been, and again, it was because there was a sort of there was a fairly switched on acute medic who kind of went, hang on a minute, she's just come from Nigeria, and requested the blood film, especially in the case of when you've got so many febrile patients in A&E, it's easy for them all to kind of get bungled together. But what effectively happens is that they end up going to ACB, febrile and hypotensive. They get pumped full of fluid, and then you call ID once they realise what it is, and they kind of go, "Why did you give so much fluid?" So it's just worth bearing in mind when someone's a febrile traveller, don't pump them full of fluid on the outset. At least double check what's going on first.
Yeah, so there's obviously in ICU there's lots and lots of studies looking at fluid and fluid boluses and when to give and what to give and what's best, etc. But one of the trials, the FEAST trial, which I'm sure anyone doing the FICM exams probably come across, is that it was a trial looking in Africa, looking at giving fluid boluses to septic children, and actually demonstrated that if you give fluid to septic children in an African setting, it increases their mortality. But one of the major criticisms, because that's very much a different outcome to what most fluid studies found in that giving fluid is beneficial. But obviously one of the major criticisms of that is that nearly all of the patients involved, all the children, had malaria. And obviously they'll have a worse outcome if you give them 40 mils per kilo of fluid than you would if they were in a UK setting. So it's, yeah, I think fluid's quite important, particularly in the context of malaria.
Yeah, and I think, to be honest, like I said, I wasn't expecting to see any cases during the pandemic. So to see 5 in the space of 6 months when none of us were supposed to be traveling suggests that it's probably a lot more common than you think it is.
Yeah. Great stuff. So that is, unless anyone's got any more questions. So back on track next week. Next week we've got Dr. Rosie Bronnett, who's one of the palliative care consultants, talking to us about palliative care in ICU, which would be really interesting. And it's actually a resource that we have used time to time for the ECMO patients, and we probably should use more, and they give quite a lot of good insights. That should be a really interesting talk. And then we've got one of the registrars from the Royal, Dr. Ben Shucker, who's going to talk about the Tomahawk trial, which is a trial looking at whether we should do angioplasty in patients who present post-cardiac arrest without ST elevation. So really applicable to all of us really, but particularly to the guys at the Glenfield. So yeah, so 2 o'clock next week, and there'll be a QR code in the chat that'll pop up shortly for people to get their feedback, and you get a certificate automatically if you do that. So if nobody's got any more questions, we'll leave that for today, and we'll see you all next week.